Senate File 32, we're calling it Healthy Minnesota Contribution Plan. This is a change to the Minnesota Care program that we've had in Minnesota for some time to provide health insurance for lower income Minnesotans. It does represent a departure in philosophy, I guess, would be one way to put it, from what the Minnesota Care program has done in the past. Essentially, the structure of the bill is to provide an opportunity for those who qualify, and what we're specifying is that this bill would only apply to those who qualify for Minnesota Care and who are single adults without children. And the reason for that is that the Medicaid provisions, federal Medicaid provisions, apply to other recipients of Minnesota Care. And given the structure of our bill, without a waiver from the federal government, we could not have the provisions in our bill apply to the other people who participate in Minnesota Care, although there is a portion of the bill that does ask for a federal waiver to allow that to occur. But at this point, and the fiscal note does not assume that we will have that, and so this only applies to the 15,000 single adults without children. And what the structure of the bill does, you can see on page 2, excuse me, starting about line 2.19, is a chart that shows what the defined contribution would be to people who would qualify under this plan. And it is an amount that is variable by age, and there are also provisions in the paragraph above that chart that talks about a sliding scale description based on income. And the idea would be to provide people who qualify under this plan with a fixed amount of money that they would then take to the private insurance markets to purchase a private insurance plan. That is essentially the concept. There are some, the description of the bill provides for, from this base contribution, an increase for people on the lower end of the income scale. On the upper end of the income scale, it is slightly less than the base contribution. Again, the idea is to provide a fixed amount to people who qualify to help them buy insurance, but there's also an assumption that individuals are going to be using some of their own money. Currently, under Minnesota Care, people do pay a premium, a portion of their health care costs under Minnesota Care. We are assuming that is going to continue. And so what we're trying to do is allow flexibility for recipients to choose a plan that is right for them and with some help from the state. I do want to make a brief comment about the direction of this bill compared to Minnesota Care. What you have in Minnesota Care is a structure that provides a lot of coverage at the lower end of the cost scale, if you will. A lot of the things, there's a defined benefit set for Minnesota Care recipients that say you have these coverages. These they might be a lot of preventive care. There might be clinic visits and so forth, and those are covered pretty completely under Minnesota Care. The danger that we see, or the problem that we see, is that for a person on Minnesota Care who ends up with a major medical problem, ends up in the hospital, the upper limit for coverage under Minnesota Care is $10,000. And so the premium cost to the taxpayers of Minnesota to provide this coverage is pretty high. I believe it's around $6,000 a year per person, and the maximum benefit is $10,000. And if you're in the hospital for more than, I don't know, 10 minutes or a day, maybe 2 days, but you can go through $10,000 pretty quickly. And so there's a high risk and a lot of exposure to individuals as well as to providers and hospitals for people who are low income and end up with a significant medical problem. What our structure would do is assume that there will be some costs that are borne by individuals at the lower end, perhaps may even be slightly more than they're bearing under the Minnesota Care structure that would be pretty much up to the decision of the person who buys the policy. But at the upper end, with the policies that you buy in the private market, there is no cap on the insurance. It's an unlimited coverage that people have. So if they get into a major medical situation in a hospital for something that is significant, those costs are going to be paid fully to the providers and to the hospitals, which is a departure from the care that's provided under Minnesota Care. So that is the idea.
Excuse me, Senator Hann.
Yes.
Madam Chair.
Senator Perry has a question. Senator Perry.
Thank you, Madam Chair. Senator Hann, I'm trying to get this in my head here now. So what this bill is really intending on doing is to give coverage over that 10,000 level. And if that's the case, are there estimates on what the state, what it's costing the citizens of the state for treatment above that 10,000 level now?
Senator Hann.
Madam Chair, thank you, and Senator Perry. Yes, the fiscal note that we have, and I believe you may have a copy of that in your materials, makes some assumptions about what would happen under this plan, and there are significant savings, we believe. And this is only for 15,000 of the people covered in Minnesota Care. But after the plan is fully implemented, it's approximately slightly less than $50 million a year. We think that's a conservative estimate, but we think that is the savings that would be generated to the people of Minnesota taxpayers by using this structure rather than the structure that we're doing. And I don't want to suggest that there is no coverage at the lower end. There certainly are coverages available, and we've got some examples of plans that show, I think those are also in your packet, that show premium costs. These are commercial plans and show benefits, and this is not to suggest that people who buy a insurance product in the marketplace cannot get preventive coverage. They can, they do, they can't. They are mental health and chemical dependency coverages are available. So this is not to suggest that there is no coverage at the low end. All we're suggesting is that there is a little bit of a shift in emphasis. I believe that it's fair to say that the Minnesota Care program is designed to cover more of those lower end costs and have a significant exposure on the upper end. What we're trying to do is change that and say we want to make sure that on the upper end, where the things are most costly, that there is coverage, and assume that on the lower end that people are going to be in a position to provide more out of their out-of-pocket costs to cover their health care costs on an ongoing basis. But we think that there is a savings. That's what the fiscal note would show. But we believe that in addition to the savings, there are good principled reasons to prefer this approach rather than the one that we're currently doing, which is simply to try to pay high medical costs with taxpayer dollars. And we don't believe that that structure is sustainable going forward.
Thank you.
Madam Senator Chair. Newman, I believe had a question.
Thank you, Madam Chair. Senator Hann, a couple of weeks ago, Senator Magnus had introduced a bill regarding the EBT cards where there was some or to try and correct some abuses with utilization of those cards. And in under this bill, it appears that a financial contribution would be made on behalf of individuals, specifically to be used to purchase health care coverage offered in the private market. Could you explain to us what protections that we have to ensure that the money we are putting up, in fact, will be used for the purpose required under this bill?
Senator Hann.
Thank you, Madam Chair, and Senator Newman. Yes, this is a structured similar to perhaps a voucher might be one way to put it. There is a I think that the cost is paid directly by the Department of Human Services directly to an insurer, so that the cost is that we are assuming are going to be paid would be paid to an insurance company for a premium cost. There's also provision in the bill that suggests that the state can only pay 90% of the premium cost. The idea here again is to make sure that when the individuals who qualify under this plan, that they're looking for an insurance program, they recognize that they're going to have to pay a part of that premium themselves. The rest will be covered by the state contribution. But that will happen directly from the state, so it will be a commercial transaction between an insurance provider and the department.
Senator Bonoff.
Thank you, Madam Chair. Senator Hann, currently in Minnesota Care, the insurance plans that provide the coverage to our Minnesota Care recipients are the private market. You know, we use Medica, Blue Cross Blue Shield. They are providing it, and I agree that having this cap costs the state and is not the right direction, but I'm concerned about the low-end high deductible. So wouldn't it be in the state's best interest to use our muscle to negotiate with these private plans and require them or ask them to add an additional product to their offering? I've spoken to them, and they don't offer a product to this population that would have a low deductible. And as we all know, one of the surest ways to control costs is to make sure people are doing the prevention pieces of their health care, and that's why we've had such a focus on managed care, because that puts some onus on the doctors to make sure that prevention efforts are underway. So I'm concerned if we put this population into the marketplace with high deductibles, the first thing that'll happen is the prevention care will go. So I don't disagree with necessarily the approach or for sure not lifting the cap, but it seems as if we put these, that currently we are in the private market, but we're negotiating on their behalf. So if in fact we could offer them more choice, but couldn't we still negotiate collectively with the private providers to accomplish both of what you're saying?
Senator Hann.
Madam Chair and Senator Bonhoeff, that's a good question. I'm going to actually ask our insurance experts here in a minute to respond more in detail, as they know this better than I do in terms of the structure. But I think one of the problems that we're seeing currently is that the structure that we use under Minnesota Care, there's a capitated rate. There's a flat rate that is paid per participant, and that is, as I understand it, in the insurance market, that's an old idea that was debunked 20 or 30 years ago in terms of how to pay for insurance. What we're really doing here is asking people to go apply for an insurance policy and go through an underwriting process. And that allows the insurers to make a judgment about what the health conditions and what the cost might be for a person who buys a policy. There is an assumption that some of the people that are in the Minnesota Care pool would not make it through the underwriting process, and there are provisions in the bill and in the fiscal note that have that assumption and suggest that those people would end up in the MCHA structure, and there is actually a higher addition to the defined benefit contribution structure to help pay for the higher cost of the MCHA insurance. So I'm not sure that having the state get involved is the right way to drive down costs. I think the right way is to get the marketplace to work and to allow people to have the ability to make judgments about what's right for them. I would just say, too, that given what the governor has proposed in his budget last week, you may remember part of it was a reduction in coverage to people under Minnesota Care. Essentially the same population, single adults without children. The governor is proposing to cut half of those people, the upper end of the income scale, out of Minnesota Care completely. So they are completely uninsured. And he's projecting a savings of about $30 million. This plan, all those people stay covered, and it saves the state $50 million. We think this is a much preferable way to do this than what the governor is suggesting. But I want to let our testifiers answer your question a little bit more completely, if I may.